for joining. Today's webinar is sponsored by Brighten Heights. Brighten Heights will be a first of its kind senior living community located in Pewee Valley, Kentucky. It will promote a life of vitality and healthy living and change amongst seniors. It is expected to welcome seniors in the 2024 timeframe. For more information on Brighten Heights, you can visit the brightenheights.org website. Here in a moment, I will introduce Dr. Youngberg, who will then introduce our guest, Dr. Bredesen. But first, just a few housekeeping items. If you are joining us through Zoom, you can ask questions through the chat window, or if you are joining us through Facebook Live, feel free to leave your questions in the comments. We will monitor them throughout, and at the end, we will have some time for questions, and we will answer those in the webinar. The Brighten Heights Vitality Series is for informational purposes only. This episode does not constitute medical advice, and viewers should seek opinion of a healthcare professional. All right, so Dr. Youngberg, I've introduced you many times, but just for those of you who may be joining that don't know him, his daily practice is in the Youngberg Lifestyle Medicine Clinic in Temecula, California, and he devotes about 70 to 80% of his time with helping people with reversing cognitive decline using the Bredesen protocol. He's an assistant professor at the School of Medicine and Public Health at Loma Linda University and a fellow and founding director of the American College of Lifestyle Medicine. He has written 3 books, Goodbye Diabetes, Hello Healthy, and Memory Makeover. All right, so Dr. Youngberg, I'll turn it over to you now.
Well, it is indeed my pleasure to introduce Dr. Dale Bredesen because that's my claim to fame, is knowing Dr. Bredesen and having the distinct pleasure of being mentored by him over the past 5 or more years in this field of functional neurology, and with the opportunity to dramatically improve people's cognition at all levels of cognitive decline. When I first started trained under Dr. Bredesen, and I believe it was 2016, at the Buck Institute for Aging, where he was the founding president and CEO back in 1998. My, how time flies, doesn't it? It was there that I began to understand what was really possible by following the protocol that Dr. Bredesen has developed over decades of his research as a research neurologist. Dr. Bredesen, I tell you, your book, the First Survivors of Alzheimer's, has greatly encouraged me, even after years of doing this pretty much full time with my patients. A wonderful overview of what is possible at all stages of cognitive decline, whether it's subjective cognitive decline, whether it's mild cognitive impairment, or various levels of Alzheimer's. And in my book, which Dr. Bredesen graciously did a review of, really was a story, right? A story like Dr. Bredesen is going to be sharing with us today. A story, in this case, of a neurologist who referred to me his patient who had advanced Alzheimer's for 5 years. And at first, I was afraid to take this patient. I didn't want to give false hope. And I tell you, applying the principles and the strategies that Dr. Dale Bredesen taught me back about 5-6 years ago, just did an amazing job as somebody who was literally an invalid, more so a vegetable, essentially, no longer able to function in any appreciable way in life. And now some 5 years later, after initially having 5 years of advanced Alzheimer's, she is very functional. She still technically has Alzheimer's, but her husband says, I have my wife back. She laughs at my jokes. We're able to communicate. We're able to go on walks together. We're able to do things that we were never able to do previously. And so that just showed me that there's never a time when you can't expect, there's never a place in somebody's degeneration where you can't expect some level of improvement or some level of decrease in the decline, because I've seen it happen so many times with the patients applying Dr. Bredesen's protocol. So Dr. Bredesen, you got your MD degree from Duke University, a medical school. Then Dr. Bredesen served as the chief resident of neurology at University of California, San Francisco. Then he joined the Nobel laureate, Dr. Stanley Brusner, his laboratory at University of California, San Francisco, as an NIH postdoctoral fellow. Okay, and of course, has been on the faculty of multiple universities, including UCLA and UC San Diego. So currently, of course, best known for the End of Alzheimer's book, and now his newest book, the First Survivors of Alzheimer's. So Dr. Bredesen, it is indeed a privilege to have you present to us today. But before you do that, I want to just say a few words about why we call it the Bredesen protocol. And bottom line is, because I get that question from time to time, because he's the one that started it all. You know, Dr. Bredesen is the neurologist that basically broke the mold of neurology. You know, I guess I like to think of you as a neo-neurologist, right? Somebody who was willing to think outside the box, somebody who kept asking the question, just being able to diagnose Alzheimer's and other forms of dementia and other neurologic diseases, to being able to diagnose them effectively isn't good enough. We need to constantly be asking a question: what are the underlying triggers, the underlying causes that lead to Alzheimer's and other neurologic diseases? And that's why I appreciate your work so much, because you actually taught us how to think outside of the box, how to apply information that was already in the medical literature in a comprehensive way. And so in a nutshell, the Bredesen protocol is essentially doing everything that is prudent, everything that is rational, everything that we can glean from the medical literature that's already published, but applying it in a comprehensive way to the patient according to their specific needs through significant evaluation and testing. And so I was actually going to do a whole little blurb on the Bredesen protocol, but essentially that's the core. And with that introduction, Dr. Bredesen, please share with us some of your own experiences and what you want to tell us today.
Yeah, thanks so much, Wes. I appreciate your having me, and always great to talk to you. And I appreciate all you've done for your many patients who've done so well. It's always great, as you know, it's just so great to hear wonderful follow-up stories for people who have improved from a disease that has been considered untreatable, and in fact is by most physicians still considered untreatable. So let me see if I can just share the screen. I have a couple of things to show that I thought would be of interest to people. So let me do this, and let me make sure that everyone can see that. And let's pull up this. Okay, can you see that okay?
Yes.
Great. Okay, so the first thing I just wanted to point, before we start here, I wanted to make a point about the semantics of success in Alzheimer's. I know we all just heard the whole issue about Johnson & Johnson and what happened with the talcum powder and how they reported this and all this sort of stuff. And, you know, I understand that we're always looking for better ways to go. And of course, we appreciate all the great work that the pharmaceutical companies have done to get better outcomes. But it's important also to look at the truth. What were the outcomes? So if you take someone who has mild cognitive impairment or Alzheimer's, and those are the last two of the four stages. And I think one of the big issues that has slowed up people getting better results is that they wait so long. So the first stage is where you're asymptomatic. You can often already show changes on a PET scan or spinal fluid. Second stage is subjective cognitive impairment, and that lasts about 10 years. So we really have a huge opportunity to reduce the global burden of dementia. And this is by definition where you know there's something wrong, and your spouse may know it, your coworkers may know it, but you're still testing within the normal range on tests. And then the third stage is called mild cognitive impairment. So when the doctor tells you, oh, don't worry, you only have mild cognitive impairment, this is like saying to someone, don't worry, you only have mildly metastatic cancer. It's a late stage of the underlying process. And yet that's where we do our trials with MCI. And then the fourth and final stage is called Alzheimer's disease, where at that point you've begun to lose activities of daily living. So the test that was done, and everyone heard about the drug back on June 7th, the FDA approved a new drug called aducanumab. And if you have no treatment, you lose here about 3.4 points on a 30-point cognitive scale. Whether you use a MoCA score or an MMSE, it's about that much. Now you can see here aducanumab, and this is in the best result that they had. In one trial, there was no improvement whatsoever. In another trial, there was only improvement at one dose. So one dose, one trial, the best it did was to slow decline by 22%. So instead of going down this much, you go down that much. The trial I'll show you today, the people actually improved. And I'll show you the trial that is now, it's publicly available. You can see it on medRxiv. So it's important to remember the semantics of what we call success in Alzheimer's disease. So I want to go back to the basic research. Everything comes from translating the basic research. And as Wes mentioned, I was trained very classically as a neurologist and neuroscientist. Spent time at Harvard, at Duke, at UC San Francisco, worked for a Nobel laureate, as Wes mentioned. And I knew that when I finished my training, there's nothing you can do about neurodegenerative diseases. This has been the area of greatest biomedical therapeutic failure, whether it's Alzheimer's, whether it's ALS, whether it's frontotemporal dementia, whether it's Lewy body disease, and just go right down the list. As people say, everyone knows a cancer survivor, no one knows an Alzheimer's survivor. Well, let me show you some of the first ones today. So our research showed that there are, and what we ended up doing is just translating the research into what can we do in the clinic that is based on the fundamental results from our research. So if you kind of open the hood and go into Alzheimer's disease, what you see is really interesting. And it shows you that it's fundamentally different than what people have thought. So this is meant to represent a single neuron, a single brain cell. And as you can see here, this is a molecule that sticks. This is now right here is the membrane of the cell. And this molecule, which is especially in neurons and especially at their synapses, is called APP. That's for amyloid precursor protein. So this is the stuff that is the parent for the amyloid that has been vilified in Alzheimer's disease. But what is it actually doing? Well, it turns out to be a really interesting molecule. When things are good, then this is just like the CEO, just like your president of your country. This says, okay, we're going to build and maintain connections. So it is cut at a single site. It sends out two memos, one for outside the cell, one for inside the cell. And what it says is things are good. We have enough nutrition, enough hormones, enough growth factors, not too much inflammation. Everything's good. We're going to be able to make new memories and keep new memories. On the other hand, when things are bad, you don't have enough support, or you have too much demand, too much inflammation, infection, toxins, things like that. This same molecule says, uh-oh, we have to pull back. And by the way, there's a direct analogy to what happened in the pandemic. So a year and a half ago, we were all told, uh-oh, we better shelter in place, socially distance, pull back, don't go to work as much. And what happened? Of course, we went into a recession. Your brain is doing the exact same thing with Alzheimer's. When there are these various insults, it switches from a growth and maintenance mode to a pulling back, a protective mode. So here is the amyloid, again, that everyone has focused on this one thing here. But as you can see, it's a much bigger story. When things are bad, your brain says, okay, I can't function. I don't have enough support to do what you're asking me to do. So I'm going to now protect myself. This amyloid is quite good at killing bacteria. killing fungi, killing viruses, protecting you from metals. It's amazing what it does. So it is responding to these things. And so then you downsize the brain. And just as Wes said, as long as there are problems, you continue to downsize. When you now address that, people do much, much better. So what that means, just to show you what this means fundamentally, is that your probability of getting Alzheimer's is ultimately related to basically four things. Do you have ongoing inflammation? Do you have ongoing toxins? Do you have enough energy? Do you have enough trophic support? And all the things that we do are directed to those four major components so that we can literally change your brain from saying, oh my gosh, I got to pull back because things are bad, to, hey, things are very good. And again, this is exactly what our country is doing in the pandemic, trying to get enough support so that we can say, yes, it's time for everybody to grow again, travel again, do business again, all the good things you need to do. So let me show you some examples of some of these survivors. And there's a nice story about Edward. And when I wrote this book, I was just so impressed by the stories of these various people that I asked 7 of them to write their own stories. And these are people that had been told, it's over. As an example, Edward, very successful professional. And he was told by the neuropsychologist, you have early Alzheimer's, you're going to have to go into a nursing home at some point, and therefore you need to shut down your practices, you need to move on. And he actually had started 2008, but by the time 2013, which is when his wife brought him to me, December of 2013, he had really done very poorly on his cognitive tests. He'd also had a PET scan that showed very clearly he had Alzheimer's disease. There's a classic pattern, and it's kind of what you could guess. You don't have the ability to metabolize glucose, and it happens to be in a particular pattern, the temporal lobe and the parietal lobe in your brain. And again, this fits perfectly with you're not able to handle energy appropriately. And you can see how bad his scores were here. California Verbal Learning Test 2, Part B, just horrible scores. Total recognition of hits. Here's CVLT2 total, his auditory delayed memory, his reverse digit span, all these things. He was doing quite poorly. So we started him on the protocol. He got much, much better. And after 2 years on the protocol, he was back. In fact, he opened a new business and kept his 2 old ones, opened a new one. And I said to him, look, would you consider coming back? We really would like to document. Let's see where you stand. And he said, look, I really don't want to do this, because I don't want the neuropsychologist to tell me that it's just all in my head. It's like, I'm thinking I'm better, but I'm not really better. We finally convinced him, look, this could help lots of other people if you could show that indeed you are better. So he finally came back. And interestingly, I got a call from the neuropsychologist as I was driving from UCLA back up to Northern California. And he said, you've got to come see these results. He said, I've never seen anything like it in my 30 years of practice. This guy is really much, much better. And you can see how much better he did on these. Very, very bright guy, and continuing to do very, very well. Here's another person. Also, her story was in the book. And I should say, Edward has a beautiful story that he wrote in the book, First Survivors of Alzheimer's. Here's Marcy. She also has a story in the book. And she herself is a psychiatrist, and she talks about her own issues. She lost hundreds and hundreds of dollars because she would go into New York City and get parking tickets, and she would never remember to pay the parking tickets. And so she'd end up getting all these hundreds and hundreds of dollars of parking tickets. So she did beautifully. Again, you can see just dramatic improvements in her cognitive score. And interestingly, she also improved her hippocampal volume. That's been one of the really exciting things, to see people actually improve their volume of regions of their brain. And the hippocampus is the most important one for Alzheimer's disease. Here's another guy, brilliant physician himself. Both parents died with Alzheimer's. He had the classic story. He had the Alzheimer-related gene, which is called ApoE4. If you have 0 copies of that, your chance of getting Alzheimer's, it's about 9% for your life. It's not 0, but it's not too large. If you have a single copy, and that's 75 million Americans, it's about 30% chance during your lifetime. If you have 2 copies, and that is about 7 million Americans, your chance is well over 50%. Most likely you will develop Alzheimer's disease. So we'd like everybody to find out, get on active prevention, and do very well. This guy already had reduced hippocampal volume. He had a PET scan that was classic for Alzheimer's disease. So he was really struggling. Now you can see here why he was struggling. His HSCRP, which is a measure of inflammation. He had a lot of inflammation. He had a lot of homocysteine, which is related to your ability, a number of things, but related to ability to methylate. It's important for detoxification, among other things, important for vascular disease. His was way too high, shouldn't be over 7. His vitamin D should be up in the 50 to 80. His was 21. His testosterone was low. His thyroid was low. All of these things. He responded, and he and I argued about this when he first came to UCLA, and he said, hey, I know that none of these things is a cure for Alzheimer's. And I said, look, give me 6 months. If I can't make you better in 6 months, then go somewhere else. And he said, there is no other place. So I said, all right, well, then just give me 6 months. And he responded absolutely beautifully, metabolically, cognitively. His MRI got better. His neurologist called me and said he's back to normal. He's doing very well. And you can see here, his hippocampal volume went from lower than normal, 17th percentile, to actually higher than average, 75th percentile. He's doing very well. And you can see here his numbers, they're not perfect. His HSCRP didn't get below 1, but it was much better than it was. So he really turned the corner and did very, very well. And his gray matter volume increased by 23%. So really striking improvements in his gray matter volume. So the reality is, as Wes said, this is really a time for a revolution in medicine. We were all trained in medicine to make a diagnosis and write a prescription. And that was the idea, or else send the person to surgery. And it's turned out that that's the way for 20th century medicine. If you have a simple disease like pneumococcal pneumonia, yeah, you write a simple prescription for penicillin or cephalosporins or things like that. But when you have a complex chronic illness, you need to look at all the different things that are contributing. It's just looking again at how are we going to get better from the pandemic? You don't just hire one person. You're going to look at all the things. Can we get some antivirals? Can we get a vaccine? Will that help people? What about other things? Do we need monoclonal antibodies? Do we need to have people with better biochemistry, improved zinc, improved immune systems, improved vitamin D? These all play a role in getting us past this problem. So we want to use this sort of approach. And I want to just summarize the trial that we did. We had a wonderful trial. As I say, it's now, it's publicly available. You can look at the information on medRxiv, which is MEDRxiv, medRxiv, which is where a lot of the information on COVID-19, for example, is stored as well. So we looked at cognitive scores. 76% of the people improved. This was statistically significant at the level of 0.001. And I should mention, I was really blessed to do this trial with 3 absolutely fantastic physicians, Dr. Kat Toops, Dr. Anne Hathaway, and Dr. Deborah Gordon. So really wonderful to work with them. And we're now actually just in the middle of planning a larger trial, which will be starting early in this new year. Neurocognitive index, and this is a very sensitive indicator that's done online, so really pushes people to look at their cognitive abilities. 84% of the people improved, strikingly statistically significant, and they also improved on specific subtests. So, verbal memory and executive function and psychomotor speed and cognitive flexibility. These were people who had MCI and Alzheimer's, so relatively late stage problems. And they did very, very well. In fact, we had a couple of people who went from MoCA scores of 19 to 30, perfect 30. So they did very, very well. Always great to see that. Then we use another one where, some of these tests in the past, people have said, well, we can't really tell any difference in the patient, but you could see a tiny effect of a drug. So we also asked the spouses and the partners, did they get better? And they indicated many of them. So they had about 86% of those improved. So again, statistically significant based on what the spouse noticed as well. And then the brain training scores improved in all of the patients. And finally, the MRIs, the gray matter. So if you look at gray matter, which is basically where the neurons are in your brain, then what happens is as we age, it slightly decreases each year. If you have Alzheimer's or pre-Alzheimer's, it goes down more quickly. So we wanted to see, could these people be less like Alzheimer's and more like normal? What was interesting, their gray matters actually went up, not down. So even though they had MCI or Alzheimer's, their gray matters were better than people who had no symptoms at all. And then finally, their hippocampal volume did decline slightly, but again, less than a normal person of that age. So in all respects, they did better than people, even people who had no cognitive complaints. It was very exciting to see. So I just want to say that, this is a time we've all been through, humanity has been through the issue of all these things that we worry about. Of course, all of us worried very much about HIV at one point. We worry about COVID-19. When I was a little boy, my mother worried very much about polio because it was a big issue. Most of us now don't wake up in the morning worrying about leprosy or polio or things like that. This is the way things are headed with Alzheimer's. Alzheimer's shall become a former scourge, and it's up to all of us to make it so by getting in early, by getting the appropriate tests. We recommend that people get what we call a cognoscopy. Just as we know when we turn 50, we all get a colonoscopy. If we're 45 or older, we should have a cognoscopy, and that's pretty straightforward. Get some blood tests, get an online cognitive assessment, and if you have symptoms already, also get an MRI with volumetrics. But if you don't have symptoms, you don't even need to do that. So it's pretty simple to do. I'm going to stop the sharing here so we can talk a little bit. But I think this just shows that there is a tremendous amount we can do, and things really are fundamentally changing the way we think about, prevent, and treat cognitive decline. So again, thanks very much to Wes and to Brighten Heights and Susan and everybody for the invitation today.
Wow, awesome. Thank you so much, Dr. Bredesen. I feel you took me back about 6 years when I was sitting listening to you present for the first time these principles. And and as of course, I've been in lifestyle medicine for 30 years now, and it just resonated so powerfully with me because you were basically establishing that the goal here is to figure out what the underlying causes are. Causes plural. There's multiple causes, and I wonder if you'd expand briefly as our first question. I remember that slide that you showed years ago of a warehouse with multiple dozens and dozens of gaps in the ceiling and the roof, and you explaining to us that that typically the approach in medicine up until recently, especially for Alzheimer's, is trying to find that one hole. We could just plug up that one hole, and we would find the solution. And then you're going like, is that a reasonable thing to be looking for when everybody who walks in can see that the emperor is wearing no clothes, right? Everybody can see here that you got to fix all the holes here, at least most of them, so that then the body can fix the rest. The ones that we don't see or are not aware of, the body could potentially fix those if we give it what it needs to begin to repair itself. Could you explain a little bit more about how you came up with that understanding and expand on that concept?
Yeah, it's such a great point. So the point we were interested in, what is the fundamental nature of Alzheimer's disease? And what we discovered is that fundamentally Alzheimer's disease is an insufficiency, but it's an insufficiency in a network. So we think in terms of, we have a deficiency of vitamin C and you get scurvy, or a deficiency of vitamin D and you get rickets. But imagine that you have a deficiency, an insufficiency of an entire network. So let's say that, you have a huge company and it's going into the red instead of the black. Okay, so you want to know what's doing that. Are people stealing money? Are there people not working hard enough? Do you have a lousy product? Do you have competitors? What is it? And this is the way this disease really is. It is your brain that is now looking at a situation where it doesn't have enough support. And so you have to look at two sides. You have to look at what's the supply, and you have to look at what's the demand. So if your supply is too low and your demand is too high, your brain is going to pull back. It simply cannot operate. You've got almost 1 quadrillion synapses. You have this amazing supercomputer inside your skull. And so you've got to support that. And as you indicated, there are critical things. So on the demand side, anything that is causing too much inflammation over the years, and that is turning out to be a poor dentition. So you actually, it's amazing to me, the neuropathologists find P. gingivalis, which is one of the things involved with cavities and poor dentition, in the brains of patients with Alzheimer's disease. And in fact, there was a company, Cortizyme, that just did a trial of just one medicine, which just tries to prevent those bacteria from, it's a specific protease they make, which is called gingipane, and it inhibits that. And for people who had this in their mouths, there was a small effect. It didn't make them better, but it slowed their decline. So, again, saying that's one of the 36 holes, just as you indicated. Chronic sinusitis, leaky gut, one of the most common, where people don't realize that they have got some leakiness, that they are actually getting systemic inflammation. And as you know, this is now associated with many things, from cardiovascular disease to arthritis and degeneration of the brain as well. Probably the most common is your area of expertise, which is insulin resistance. So people, incredibly common, and they usually quote numbers like 80 million people in the United States have insulin resistance. It may be more than that. So we're always looking at their HOMA-IR. We want to know their fasting insulin. We want to know their fasting glucose. We want to know their hemoglobin A1C. And now more and more, we're interested in their CGM and their continuous glucose monitoring. So you can see people are, as you know, so surprised. They eat some health food and their glucose will skyrocket. Then they go to bed and it goes plummeting down to 40 and they wake up in the middle of the night. Why am I waking up? Yes, because you have hypoglycemia. Both of those are very bad for your brain. So smoothing that out with appropriate diet, huge. And so again, we didn't start out with any interest in lifestyle. We came straight from the test tube. But if you just look at what drives those molecules to signal downsizing, it is, as I say, the demand. It's the inflammation, the various pathogens, even things like tick-borne illnesses, various fungal infections, things like that. And then it's toxins. As you know, so many people have exposure to mycotoxins. And I was never taught in neurology residency that in fact mold-related toxins were one of the causes of cognitive decline. I had to learn it the hard way by having patients come in who ended up had these various mycotoxins and did better when those were then removed. And then on the side of the supply side, it's growth factors. It's things like brain-derived neurotrophic factor. One of the biggest issues with energetics, which is one of the big ones, is that people will have some sleep apnea, or they don't realize that when they go to sleep at night, they are decreasing their oxygen saturation, and doctors aren't typically checking for it. And so it turns out that's an important one. If you don't have enough oxygenation for your brain at night, what do? You downsize. In fact, there's a beautiful paper published a couple of years ago where they simply looked at the average oxygenation while people slept. And literally, it was a direct correlation with the size of specific nuclei within the brain, including the hippocampus. So the very things that are critical for our memory and for Alzheimer's disease are going down as our oxygenation is going down. And then, of course, blood flow. People don't realize how important it is to get that blood flowing, which is why exercise so helpful. And so I'll often hear the story, well, I'll do a little walk occasionally and then sit on the couch. That's not supplying your brain with what it needs. So again, we come back to the fact that this is fundamentally a network insufficiency. And it is, as has been pointed out, this has been a kind of pandemic within the pandemic. We've got a pandemic of Covid-19, which has now claimed the lives of over 700,000 Americans. But in fact, the pandemic of Alzheimer's is much larger, of the currently living Americans, about 45 million of us will die from Alzheimer's if we don't do something about it. And thankfully, now there is a tremendous amount you can do about it, and the earlier, the better. So it's all these different things, and these come up all the time. It is your diet, it is your exercise, it is your sleep, it is your stress level. We have people who literally, as their stress goes down, their cognition goes up. As their stress goes up, their cognition goes down. Amazing. And it is the various toxins we're exposed to. These are all critical pieces. And the important thing is, you can look into this. You can find out what's actually driving the problem for most of these people and do a fantastic job with improving that.
You know, Dr. Bredesen, speaking of COVID-19, I wasn't expecting this, but we presented on this topic because that we're dealing with a senior population, a high-risk population, but as I look at my patient population, all those individuals that I have been doing the RECODE program, the Bredesen protocol on, I have not lost one of those patients to COVID-19 death. Now, many of them actually did get COVID, okay? Yep. But none of them died from COVID. Now, I bring this up because this is a startling finding. I'm not as startled as I might have been before, because it makes sense, because it's not just the comorbidities, the conditions that we get labeled with. It has to do with, are we actually doing something about it? And so what I credit the success, the ability of these patients to survive, even though they were very high risk with multiple, many times 6 or 7 comorbidities, none of them succumbed. None of them died from COVID-19. And I credit your protocol to this, because we were addressing every single underlying factor, every potential cause that we could determine for inflammation, optimizing the vitamin D, optimizing the homocysteine, optimizing every area that is part of this comprehensive protocol. And this is something that, unfortunately, the world and our health agencies need to take notice of. Is that if we want to save people, if we want to prevent the only 2 things that ultimately matter, which is hospitalizations and deaths, ultimately, that the most important way to do that is to follow the principles that you have laid out in the Bredesen protocol.
So, there's a great parallel here between COVID-19 and Alzheimer's disease. And actually, I wrote about it in that book that you showed earlier, The First Survivors of Alzheimer's. What's really interesting, if you look at the biochemistry and you look at the immunology, what happens with COVID-19 is you have too much inflammation. So you have your innate immune system, which is the older evolutionarily part of your immune system. You've got this cranked up, and your adaptive system has not succeeded. It's supposed to clear the virus and then turn off the innate system and kind of reset things. But unfortunately, when it's not operating very well, you just have this continued inflammation. And what do we die from? We die from, as you know, cytokine storm. That is because you haven't completed that. Now, in Alzheimer's, it's the same thing. Alzheimer's is often related to the innate system is going overtime, but the adaptive system hasn't cleared. It hasn't cleared, whether it's herpes from your lip, whether it's we talked about earlier about leaky gut, whatever it is, it hasn't cleared it. Now, the difference is, instead of cytokine storm, you're dying of cytokine drizzle, because what happens is this is a chronic condition that goes along for years. Typically, it's 20 years from the beginning of the changes in your brain to a diagnosis of Alzheimer's disease. So cytokine storm in COVID-19, cytokine drizzle in Alzheimer's, but it's very much the same principle.
Now, Dr. Bredesen, you and I have heard many times talking to a patient where it may be a family member, they say, well, it's really not that bad. In other words, they're looking for an excuse not to put energy and time into the protocol.
Right.
And and you talked about this in the introduction to your book, and
Yeah.
I quote, says, I can't tell you how many times I've heard from a patient that it's not that bad. My spouse isn't actually that great either, and suggesting that since we're about the same, that there's really no need for doing anything differently or intervening in any way. Now you have, you're well known for what is called the RECODE program, and also the PRECODE as it relates to this cognoscopy, this evaluation that really all of us, in middle age or after age 40 should be taking advantage of. Can you expand on that with respect to this? Oh, it's not really that bad. I can wait.
It's a great point, and maybe the most important point of all, because this is, unfortunately, this is something that sneaks up on us, and that's been one of the biggest problems. So this, unfortunately, you really want to get in early, because we think about, the cognoscopy, and I have to say the cognoscopy is much more pleasant than a colonoscopy, much easier to do, and it will save your brain. So this is why we recommend that everyone does it. And so what happens is people will not realize, they'll say, well, I'm not that bad yet. And so there's this tiny micro step changes, and we get to the point where things are really bad. And now we want to jump in, and it's much harder. The farther you get along, the harder it is. This is why we encourage everyone to get in. Please get in as early as possible. And a good example, we had the guy that I showed you earlier who had this dramatic improvement in his gray matter. He said to his wife, something is just not right here. I'm having problems. He then went and got evaluated. He had abnormal PET scan. He had abnormal, abnormal MoCA score. Everything was abnormal. And his wife said to him, oh, you're just getting a little older. That's all it is. This is just a senior moment. Well, no, this just shows how far. We had one woman as an example who came in and said, I think I'm just here for prevention. But there's a lot of Alzheimer's in my family, and I'm worried. And she was ApoE4 positive. And when we tested her, she already had a MoCA score of 23. So she was well into mid to late stage MCI, mild cognitive impairment, thinking everything was okay. And so now, by the way, hers is now 30, perfect 30. She's doing absolutely great. So I urge everyone, please get in early, preferably for prevention if you're 45 years of age or older. But if you fail that, or if you don't do that, please then, if anything, if you start getting any symptoms, please come in, because we can reverse pretty much 100% of the people who have SCI, most of the people with MCI, and some of the people with Alzheimer's disease. But it's harder and harder. You have to do more and more. Again, this is not surprising to people when you think about cancer. We all are used to the idea that, hey, pap smears change the world. Colonoscopies change the medical world. Chest x-rays, mammography, all of these things have helped us for cancer. Why are we not doing the same sort of thing with cognitive decline? This is what's going to really help and make sure that people do not get Alzheimer's disease.
Now, I speaking of getting in early for the cognoscopy approach, we also want to thank people who wrote in questions early by email yesterday and before. And so I want to ask a couple questions from our audience now.
Sure.
And one is this protocol that we're talking about now for dementia patients, is it appropriate for somebody with a brain bleed? And I know you have comments on that.
Yeah, it depends on what's the cause of the brain bleed. For many people, what happens is if you have two copies of ApoE4, so males, especially with two copies of ApoE4, can have amyloid angiopathy. This is where the amyloid that we talked about earlier that comes from that APP actually gets into the blood vessels and can be associated with some bleeding. And yes, the protocol is fine. you simply want to make some minor modifications. You don't want to have people, for example, on omega-3s. You don't want to decrease their clotting abilities. But again, it's important to know what was the cause of the hemorrhage. Was it a traumatic hemorrhage? Was it a subarachnoid hemorrhage from a barrianeurysm? Was it a lobar hemorrhage from amyloid angiopathy? Was it a hypertensive hemorrhage, which is typically in the deep matters of the brain, for example, in the putamen? So these are different kinds of hemorrhages, and it's important to know what it is.
And that highlights what you were discussing before, which is the perspective of a precision personalized medical approach. Right. Everybody gets a precision approach. This is not one size fits all. This is basically doing very broad evaluation. And then what we learn from each piece of that evaluation determines exactly what is done about that. So in the end, you have patients that might be in a very different protocol with some of the same fundamental or foundational strategies. And that's what I love about the RECODE and the Bredesen protocol, is that it teaches us to always look at what the individual needs, as opposed to, oh, you got this problem here, take this, see you later.
Yeah,
Come back
in 2 months. And it's interesting to me that we've all been trained and we've all gotten away with, over the centuries, we as physicians have gotten away with writing a prescription, which is one small molecule. And for pneumococcal pneumonia, that works. But even if you have something as simple as hypertension, what you really want to know is, why did you get hypertension? And it's so interesting to see. We find that people who go on the protocol often no longer need their antihypertensives. They no longer need their statins. They no longer need their anti-diabetes drugs, because they are now addressing the things that are actually causing the problem. So the revolution in medicine is to go from, we're going to treat this blindly and give you a prescription, to no, we're now going to look very carefully. Human beings are incredibly complicated organisms. So we're going to look at your overall physiology, and we're going to address those things in your physiology that are causing your cognitive decline. And if you think about it for 30 seconds, it's really the only way that makes sense. To try to treat everyone the same without knowing what caused it really doesn't make a lot of sense.
Dr. Bredesen, a question I'd like to ask, that since we are developing the Brighten Heights community, obviously one of the key things is, as a senior living provider for where seniors can come and live, and our campus is going to be primarily focused on people who are at the very, what we call, independent living stage of life. In other words, they're not needing assistance with activities of daily living at that stage, and they're wanting to live a very active lifestyle and maintain that going forward. So my question to you, certainly based on your experience with people that are struggling with all these issues, how can a senior living provider best support and empower residents to be successful on this journey of preventing and reversing cognitive decline?
Yeah, this is such a great point. You're actually seeing people at the perfect time, because once they've begun to go down with cognitive decline, it is harder and harder to bring them back. We see it all the time, but it's harder and harder. If everybody would get on prevention or earliest reversal, which is what you're going to be seeing in the senior facility, then you could really make this a very, very rare disease, which is what it should be. So you can do a couple of things. One of them is to offer a simple screen. And we're actually looking at this. We're working with a large group now that looks at these very sorts of things, to look at, okay, what is a simple screen that we can offer that would be essentially like a cognoscopy? We can offer each person so that everybody can get this, that is inexpensive, that will look at these critical parameters. Because, when people first started looking at cholesterol or glucose, things like that, they would find these people that were, way off the charts and just didn't know it. And they were on the way to something bad, but now we know what to do. We can catch them early. Just the whole concept of pre-diabetes is a relatively new concept. It wasn't around 50, 60 years ago. And so that's the first thing, to offer everybody a simple way to look at what are your risk factors. And then the other half of that, of course, is to offer an ability to address it. And having someone like Dr. Youngberg, who's interacting with you, who can make sure that people are optimizing their protocol. And we've written software for this that helps people to understand what are all the things that are in each case that are offering this. You know, it's so interesting to me that, Google knows where you shop and knows where I shop and where Wes shops and everybody. And they've got these wonderful, amazing algorithms looking at where are you going? What are you doing? How should we target you? Why are we not using that same sort of approach to make sure that nobody gets Alzheimer's disease? I think that's where things are headed, to be able to look earlier. And so I think offering those two things, an evaluation that is available to everyone, and then appropriate things, and that includes general things plus specific things. The general things are going to be things like a mildly, plant-rich, mildly ketogenic diet, which is what's worked the best for everybody. People can check their ketones. You can do it easy. I just blew into my breathalyzer this morning to check my own ketones. You can see where you stand. And so, one of the things that's really intriguing to me, these wearables, and wearables are now everywhere. Oura rings and Apple watches. And you can now look at your everything from your ketone level to your continuous glucose monitoring to your telomere length to your your microbiome of your gut, to your heart rate variability, your blood pressure, on and on and on. So to have some of these simple things so that you can actually follow people is going to make it so that you can prevent virtually 100% of these people from getting dementia. Imagine a place where people come and they say, I'm going to Brighten Heights because they have published that their rate of people converting to dementia is 0.01%. That's where things are headed. And that's what you could do that would be so fabulous. Imagine if people could know, hey, I'm going to Brighten Heights because I know I'm not going to get demented if I'm there.
Yeah, that would be awesome.
Yeah, absolutely.
That's the goal.
Now speaking about the keto diet, Dr. Bredesen, I know we are always constantly asked questions that are controversial. And
Yes.
one of our doctors is asking a question here. How do you reconcile the two diet paradigms? The keto flex diet conflicts with what Dr. Youngberg advocates for reversing diabetes and insulin resistance, which is a low fat, especially low animal fat diet. So that was the question. Now, let me correct that statement or question by giving my 2 cents with regards to I actually do promote a plant-based diet for the most part. I encourage towards even more of 100% plant-based diet, but I do not recommend a low-fat diet. I'm always debating or discussing this with other plant-based doctors that we're promoting a diet that's rich in nuts and seeds and avocado and olives and basically whole fat foods because they are so healthy for the brain in particular.
Right.
But I've had to stick up for you many times, Dr. Bredesen, but some of my colleagues, they wouldn't even go to a program that you were speaking at, because they were so upset that you were doing keto. And I'm going like, come on, he actually is promoting more plants than you are.
Yeah.
And that's true. And so if you read Dr. Bredesen's books, it's dramatically promoting lots and lots and lots of especially non-starchy vegetables, which are the core of any healthy diet. Like Dr. Terry Wall's diet, what I call the 3 cube diet, three cups of greens, 3 cups of colorful vegetables, 3 cups of sulfur-rich vegetables. And if more people, even those who say they are promoting a plant-based diet, focus more on that, we'd all be the healthier for it. But what is your perspective on this controversy?
Yeah, I'm so glad you brought that up. You know, there's so many controversies about what to eat. And my wife, who's an integrative physician, said to me, you know, we shouldn't be saying keto because that misleads people. People think that we're going to tell them to eat bacon and ham and things like that, which we're not. This is plant keto. So here's the thing. Again, we're agnostic, whatever helps people the most. And I'm sure there are some slight differences between improving diabetes and improving cognition. So we're just going with what are the goals biochemically to make your cognition better, especially if you've got some degree of cognitive decline. Okay, well, that's pretty well published. You want to have something that is plant rich. You need the phytonutrients. You need the fiber. You need those prebiotics. And you need some fermented to get some probiotics. You need all of those. You need a healed gut. You need some detox that you're getting from that fiber. You need to have a period in which you're fasting. And so we call it Keto Flex 12-3. We want a minimum of 12 hours because you need to cleanse your brain, basically induce some autophagy. We need the phytonutrients, but we need also to be able to provide energy. And if you had to list all the things important for Alzheimer's, you know, immunity would be right near the top, and insulin sensitivity would be right near the top. But energetics would probably be the number one thing. This is a failing brain. So why is that? Our brains operate on two things, on glucose and on ketones. And unfortunately, virtually everyone with cognitive decline has lost both of those. I'm amazed that people do as well as they do for as long as they do. They've lost the ability to use the glucose because they're typically insulin resistant and they are not metabolically flexible. They've lost the ability to make and use ketones because your insulin has to be low for your body to make the ketones. But you've got those two ways. It's a little bit like having a Prius. You're either going to have some electricity or you're going to have some gas. You can't do neither. So the thing is, we need to get you back. And what's the best way to do that? Well, it is to become metabolically flexible. So we want to get you those ketones. In fact, I think at the beginning, just take some exogenous ketones. You are in an energy starvation situation when you have cognitive decline. So at least restore that. We'll get you into endogenous ketosis later. Then begin to rebuild and become insulin sensitive. Now start to be able to go back and forth where you are metabolically flexible. And to do that, the best diet to do that right now is a plant-rich, mildly ketogenic diet with appropriate fasting periods. That's the way to get it done.
You know, as I was reading through your book last night, by the way, there's some of the questions in the chat have to do, well, which book should we start with? I tell you, Dr. Bredesen's new book, First Survivors of Alzheimer's, is amazing. All his books are great. But if you haven't read any of them yet, start with his newest book, because this is an amazing book that not only gives you examples of what is possible, but it also gives you a lot of, the last half of the book is talking about dealing with the issues. Right. And in your book, Dr. Bredesen, you brought up the challenges that, you know, so many medical professionals even are upset about your protocol. Like it's just shocking to me how somebody, in other words, they don't want anybody to succeed. We want people to believe us when we say there's no cure and there's no option and there's no hope or even preventive strategy for Alzheimer's. And we don't agree when people out there go and show us wrong. That we're wrong. So, but you specifically stated, Dr. Bredesen, you were quoting Walt Disney, who talks about two types of people. Okay, where he said there's yes if people, and then there's no because people. Can you expand on that a little bit?
Yeah, I was intrigued to read that about Walt Disney. It was actually a guy, a mathematician, who had worked with him to figure out, like, where are we going to place Disneyland to have people come there? And he said, Walt Disney was trying to do something different. He was saying, let's put something, this was in the 1950s, let's put something together that's different and that, that really kind of occupies a niche. And he said, look, the problem is that most people are no because. They either yes if means, okay, you might be able to succeed if you did some of these things. The no because are the people that always have a whole list of reasons. You're going to fail because of this, because of this, because of this, because of this. And we hear that all the time with Alzheimer's. Oh, we know this is not going to work. You know, drug companies won't do something that has 36 holes. They want one drug. Well, okay, maybe that's not the right way to do it. Or, oh, people won't do it. Well, okay, maybe we need to have health coaches for them. Everyone is armed with this whole litany of reasons that you can't do something. And so, you know, again, we just have to hammer, get the data out there, show that, yes, we can get people better. And I know, Wes, you've seen this on so many occasions. When you see people getting better from cognitive decline, there's just nothing better than that, than seeing people who really turned around from something where most of them were told it was hopeless. So that's just why I love Walt Disney's idea of the yes if people who say, well, you know, if you would do these certain things, you might make that work.
Henry Ford summarized that very point when he said, whether you think you can or whether you think you can't, you're right.
Yeah.
So, Dr. Bredesen, we're excited about what you've shared with us today. We want to be yes if people. We want to think we can because you have showed us the way. We don't have any good excuses anymore. We just gotta be willing to do that cognoscopy, okay, and pay attention to the principles of your RECODE and Bredesen protocol. So, Dr. Bredesen, once again from Brighten Heights, we appreciate what you're doing and we support you 100%. And we're so glad that you were able to take the time to be with us today.
Thanks so much. And, you know, we'll all continue to make this better as time goes on. This is the beginning. There's a lot more to do. Thank you, Wes. Thank you, Susan. Thank you, Brighten Heights. Really appreciate your having me on.
Well, thank you so much. And I just want to remind people that you can, in our drop-down window, you can find links to resources about Dr. Bredesen, the protocol, the books he's written, as well as Dr. Youngberg's information. And of course, Brighten Heights. And we thank you so much for your time and stay tuned for future webinars. Take care.
Thanks. Thanks, everybody. Stay safe.
Bye-bye. Thanks again.
All right. Thanks again, Wes. Take care. Bye-bye.